Good morning, everyone, and welcome to another Thyroid by MDS webinar. We are bringing together leading experts to discuss advancements in thyroid cancer and thyroid disease research. My name is JP Brito. I am an endocrinologist at Mayo Clinic, and I will be your host today. Thank you for joining us. Today, we are privileged to have three distinguished guests. Dr. Cottrill, Dr. Campbell will be presenting the recent article evaluating ChatGPT responses on thyroid nodules for patient education, and Dr. Pozdeyev will serve as our expert discussant. So let me tell you first a little bit about our speakers. Dr. Elizabeth Cottrill is an associate professor at Thomas Jefferson University, where she also serves as the residency program director and the surgical director of the Jefferson Thyroid and Parathyroid Center. Her research focuses on the mutational landscape of thyroid cancer diagnostics, technology, and clinical outcomes and patient education. She's an active member of the American Head and Neck Society, the American Thyroid Association, the American Academy of Otolaryngology, and the American College of Surgeons, and she serves in several national committees. Dr. Daniel Campbell is an otolaryngology head and neck surgery resident at Thomas Jefferson University in Philadelphia, with a background in neuroscience and economics from the University of Pittsburgh. He's passionate about medical education, having published extensively on patient and trainee education in otolaryngology. Dr. Campbell serves as the General ENT and Sleep Educational Committee for the American Academy of Otolaryngology, Head and Neck Surgery, and was recognized as the House Staff Clinical Educator of the Month in September 2023. As our discussant, we have Dr. Nikita Pozdeyev. Is a physician informaticist focused on improving thyroid cancer by analyzing large-scale genomic data and developing clinically relevant genetic tools. He leads research on germinal and somatic variants linked to thyroid cancer and co-founded the Virtual Thyroid Biopsy Consortium to investigate thyroid disease genetics using data from 1.7 million individuals worldwide. His work includes building an interactive genetic analysis portal and creating clinical tools such as levothyroxine dose calculators to enhance treatment accuracy. And before we dive in, I would like to remind everyone about our podcast, Voices of Wisdom. Each month, we explored groundbreaking research and expert insights in thyroidology. It's available in any of your favorite podcasts, Apple Podcasts, Spotify, and any of those. Be sure that you click and follow us. Also, I would like to remind and actually encourage the audience to use the question and answer function to post questions. I will be gathering those questions and then I will be reading at the end of the presentation. Well, now it's my pleasure to let Dr. Campbell start his presentation. Thank you for being here and share your paper.
Awesome. Thanks so much for the kind introduction. It's an honor to be presenting this morning. Well, I'm really excited to be presenting on this topic. It's a topic that I'm really passionate about. I think it's exploding and it's extremely interesting. The title of the paper was Evaluating ChatGPT Responses on Thyroid Nodules for Patient Education. And what I hope this presentation can do is, of course, present the paper and the background of the paper and what we found, but also kind of describe the paper in its larger context and where I think this will kind of bring us in the future in terms of patient education. So to start off, the National Health Institute has this thing called the HINTS, Health Information National Trends Survey data, and they have roughly the same survey questions that they ask on a yearly basis. Right now we're at the HINTS 6, which got up to 2022. There is a most recent one that's being published soon, but you can see on this slide here, they ask the question, in the past 12 months, have you used the internet to look for health or medical information? And going back from 2017, you could see that even in 2017, 70% of the users said yes to that question. And then as you kind of went forward in time up to 2022, which is the most recent HINTS data, we're up to nearly 85% of the users said yes to the question that they looked to the internet for health information or medical information. Then we go to the next question. They ask, how confident are you that you could find helpful health resources on the internet? And they broke it down to different stratifications of confidence. And 85.3% of the users said that they were at least somewhat confident that they could find helpful health resources on the internet. So taking these two statistics together, we see that patients are readily going to the internet to look for health and medical information, and they are also readily confident that these resources are good. So that brings us to the next question. Patients are going to the internet for health information, but how exactly are they using it? And for this, I kind of want to describe a paradigm, the way that I think about patient education. So on the left, we have our patient, and then we have two kind of classical ways that the patient can interact with information. The top one is the classical patient-doctor interaction, and the bottom one is the patient kind of learning at home by themselves. Now, when a patient learns at home, there's two classical ways that they can interact with resources. One of them are print resources. These are things that you may hand out at the office, like brochures or handouts. And the other one may be something like textbooks or magazines or any sort of print resource that they could read on their own. The second one, perhaps a bit more recent, are online resources. These are things like using a Google search, going to educational websites, even possibly going to a website that your hospital may provide for patients, and going to video sharing websites like YouTube, which actually is like the second most visited website globally. And just to kind of hone in on two of these things, Google and educational websites, these actually have been extensively studied in the literature, in particular for thyroid literature as well. So this is one paper from 2021. They assessed online information for treatment of low-risk thyroid cancer. And they looked at kind of the top 60 websites. They looked on Google, Bing, and Yahoo for the term thyroid cancer. And they found that rarely across these top 60 websites 18% of them referenced ATA guidelines, and only 31.8% referenced treatment options of total thyroidectomy, lobectomy, and active surveillance. So, I mean, you can see from this paper that when patients are going to the internet and using common search engines to search for information about thyroid cancer, it's pretty incomplete. The next question you have is, you could present a patient with information, but are they actually understanding it? And we'll get into this a bit later, but the American Medical Association and the National Institute of Health, they recommend patient information be presented roughly at the grade level, US grade level of 6 to 8 or below. And this kind of study in 2023 did a similar search where they looked at the 150 websites using the word thyroid nodules, and they found the mean reading level to be 11.25, which is at the kind of like the junior level of high school. So an upper level of high school, which again is above the recommended level by the NIH and AMA. And then they also calculated a PMAT score, and they found an understandability score of less than 7%. So, I mean, taking these two papers together, we can kind of see that when a patient goes to Google to ask a question or learn more information about thyroid cancer or thyroid nodules, not only is that information incomplete, it also may be at a grade level that's too high for the patient to understand. So now we're going to return back to our paradigm. Again, we're in the section of this paradigm where the patient's at home learning, and we have print resources and online resources. And another popular online resource is YouTube. And I mean, this is an example of a YouTube patient education video that we've created along with Dr. Cottrill at Jefferson. This particular one was on thyroid surgery informed consent. This is a link to the QR code to that video for an example and some screenshots of that video on the right-hand side. But I mean, the breadth of literature that exists, not only in thyroid cancer and thyroid surgery, but just overall in kind of medical education on characterizing and grading and seeing how good YouTube videos are for patient education is so wide. And generally, videos are found to be at best incomplete and at a grade level that is exceedingly high for patient education. And this is just an example of 5 videos on thyroid cancer or thyroid nodules. So again, coming back to our paradigm, we're in this realm of patients learning at home. We went through some online resources. We discussed that Google, educational websites, and YouTube, they are often incomplete data for patients, and they're often at a grade level that's presented too high. What I want to do for all these classical ways that patients are learning and educating themselves at home is group them into one category called human-made. And I'm going to put that human-made category kind of on the top part of the screen right here. And in this part of the presentation, I want to introduce a new category or kind of subset of this decision tree. called artificial intelligence or AI made. And there is a breadth of artificial intelligence, large language models that are available now that patients can go online and use this second. Just to name a few, we have ChatGPT, Google Gemini, Perplexity, and Open Evidence. And this is going to be kind of a new branch of this decision tree for a paradigm of how patients are interacting with information at home. And to kind of break this down, I am by no means a computer scientist expert, but this is just kind of a simple framework that helps me understand what exactly we're talking about, and it makes me kind of make sense of what we're reading about online with these sort of large language models. When you think about artificial intelligence or AI, these are systems that are intended to simulate human intelligence to perform tasks like reasoning, learning, and problem solving. And this is the big umbrella category that you think about with artificial intelligence. And as we kind of go deeper, machine learning, these are algorithms that learn patterns from data to make predictions or understand patterns. And then if you go even deeper than that, we have something called deep learning. Now, this uses neural networks with many layers. This is where the word deep comes from, to make predictions. And at this point, we are just interpreting data and making predictions of data. But then we have a new subset called generative AI. And generative AI is able to create new content. And then a subset of this are called LLMs, or large language models. These are the things like ChatGPT, Perplexity, Open Evidence. And large language models, or LLMs, are designed and trained to understand and generate human language. So you're able to interpret vast amounts of data from wherever you want to feed this data from, the internet, text, books, and they're able to kind of comprehend that, understand patterns, and not only return the patterns that it found, but also create and design new information that is in the wordage of the human language that we could understand. And when you're thinking about large language models or kind of the evolution of them over the long course of time, this is just a snapshot of the large language models that have been around since 2021. Now, if I were to extend this timeline, I could extend it all the way to the left and I could extend it all the way to the right. But I mean, what I want to hone in on is this kind of November of 2023, because this is when ChatGPT, or their version of it at the time was GTP 3.5, became accessible to the public. And this is when large language models became kind of in the public eye and they started to explode in popularity. And this is just a screenshot from around that time period, early 2023, of all of the news articles that we were seeing about ChatGPT and their implication for medical education and patient education. And at this time, I had so many questions about like how we could use ChatGPT, what this means for patients. And so, I mean, this is an example. This is ChatGPT and its current free form right now. And here I'm at, and I'm just asking the simple question, like, what is our foundation? What is the foundation's mission statement? And we could see what it says here. So it says the foundation's mission is to support research and education in the early detection and treatment of thyroid, head and neck cancer. It gives a pretty decent response, and it does it extremely fast. And then I ask it, what is this lecture series that we're presenting on right now? And it gives me a pretty decent answer, giving an overview of the lecture series, what it entails, and it even gives a link to the foundation's YouTube channel. So it got me thinking we can go even further in this. We could ask, what are thyroid nodules? And then we could say, are they common? Again, it gives me a very quick and comprehensive response. It estimates about 50% of people have thyroid nodules, and it says only a small percentage of these are cancerous. And then if you keep wondering, like, how much can you ask, and how useful can this be for a patient? So then I ask a very pointed question. I say, what is the incidence of recurrent laryngeal nerve injury following thyroidectomy? And this is kind of the exact thought process we had when we were kind of coming up with the inception of this paper. And we asked not only what is the incidence, but also cite references that this number is driven from. And it gives me very concrete numbers, and it gives three seemingly real references. Oh, it doesn't give a link to the references here. Well, you can see the potential of this kind of just in the backdrop for why this may be interesting for patient education. So again, going back to our paradigm, we're kind of focusing in on this artificial intelligence made aspect, and we're really honing in on ChatGPT right now. And to kind of discuss ChatGPT, it's developed by a company called OpenAI. It's been the fastest growing consumer application in history. I think these numbers are incredible. So in that November 2022, this is when it became available to the public. Within 3 months, it had 100 million monthly active users. By August of 2024, it had over 200 million weekly active users. And then by December of 2024, over 300 million weekly active users. So then this is used to an incredible degree of patients worldwide. And there's limited research has demonstrated its medical applications. This was at the time that we were that we were thinking of the study, and there were limited studies about this. We had published something about its utility in patient education for obstructive sleep apnea. There had just been two articles, very interesting, that were describing how it passed USMLE step exams. It passed a neurosurgical written board exam, and Doximity had just released a writing assistant at the time that we were thinking about this. And the next question is like, why is this important for thyroid nodules? How could it be applied here? And it's because thyroid nodules are a relatively common finding. The prevalence varies, but between 2 and 65% in adult populations. They're typically asymptomatic and benign. However, roughly 5 to 15% carry a risk for malignancy. And prompt diagnosis and initiation of treatment is critical. And because it's such a common issue, adequate patient education is paramount. And kind of what we went into a bit earlier, but there's been multiple studies of educational materials have demonstrated that there's been lots of inadequacies and inaccuracies in existing information online. And they're often written above grade levels for patients. And again, thinking about that grade level, we want it kind of at least below the eighth grade level. So the research goals of this study, we wanted to evaluate the quality of ChatGPT responses to common patient education questions. We also wanted to assess how targeted chatbot prompting strategies, which we'll get into, can influence responses. We wanted to look at the grade level of the responses, and then we wanted to interrogate the veracity of medical references provided by the chatbot. So now going forward, I kind of want to discuss how we answered each of our research goals. So firstly, we asked ChatGPT, which at the time was ChatGPT or GPT 3.5. It was queried 4 times with an identical set of 30 sequential questions. And you can see these questions on the right side of the screen right here. But they ranged in categories from epidemiology to diagnosis to prognosis and management. And we queried the chatbot 4 different times. So the question is what did we differ with each of those queries? Well, we gave the chatbot a different prompt each time. So what I mean by a prompt is we gave the chatbot a certain statement or a collection of statements before we asked the first question to see if it would influence the answers. Now, for the first set, we didn't prompt it at all. For the second set, we basically said, I'm a patient, and I'm going to ask you questions about thyroid nodules. And please be as specific as possible in your answers, but we wanted the language to see if it could make it appropriate for patient understanding. Next, we said, I'm a patient, and then we asked it to present the answers at or below the eighth grade level, because again, this is that upper limit that the AMA and NIH recommend patient education be presented at. And for the last one, we asked it for references. And not only did we ask it for references for what it was citing, but we said from published medical literature. We wanted to see if prompting the chatbot for references could allow it to give us those references from reputable sources. Now, what did we do with the answers? Well, we graded them based on medical accuracy and clinical appropriateness using a 4-part scale. We said the answers could be incorrect, they could be partially correct, which essentially could mean it's incomplete or too vague. We said it could be correct, or it could be correct with a reference. And finally, for each answer, we calculated a Flesch-Kincaid grade level score. And this grade level score is intended to correspond to the estimated US academic grade level. Finally, of all the references that ChatGPT gave us, we verify that the references are real, which essentially it was findable online, it had a DOI number, for example. And then not only do we identify that it's real, but is the information in that study correctly cited? So again, our overall schema, we asked ChatGPT 4 times using 30 questions. Each of those times differed by the initial prompting. We graded it on a 4-part hierarchical scale. We computed a grade level score for each answer. And then we investigated the veracity of the answers that were provided. So the question is, how did ChatGPT do? Well, here are just some examples. And again, the layout looks slightly different than the video I presented earlier, but this is because this is what ChatGPT looked like at the time of our study. And I ask it, what are risk factors for thyroid nodules? And this is an example of that answer. Here's another example if I ask what scoring system is used to grade FNA results and guide treatment. And here, I mean, you can see ChatGPT does go over the Bethesda system for reporting thyroid cytopathology, and it even takes the liberty of bolding each of the categories. So here is a summative heat map representation of our data. And just to kind of break this down and make it as easy to visualize and understand as possible, what we have coming down each of the rows, 1 through 15 on the left side, 16 through 30 on the right side, these are all of the questions that we asked ChatGPT. And you can see that there's 4 columns, 1, 2, 3, and 4. And each of those columns correspond to a different prompt that we gave ChatGPT. Again, our prompts were no prompting, patient-friendly prompting, 8th grade level prompting, where we said present our information at the 8th grade level, or prompting for references. And the heat map aspect of it is presented by the colors. So red represents it was incorrect. Yellow represents it was partially correct. And then the light green and the dark green is it was correct or correct with a reference, respectively. And you can see there are probably some patterns that you could recognize here. For example, question 8, it was partially correct across the board, whereas question 20, it was correct with a reference across the board. But what patterns can we glean from this? Well, across all the prompt types, and again, that equals 120 questions because we had 30 questions across 4 prompts, 83 of them, or roughly 69%, were at least correct, which means correct or it was correct with a reference. Now, the next question is, does prompting or the difference in columns here, does that affect response quality? And again, these were our 4 prompts that we gave. We had the no prompting category. We had the patient-friendly prompting category, the 8th grade level prompting, and prompting for references where we said, make it come from published medical literature. And what we found is that, in order for an answer to be at least partially correct or at least correct, there was no difference in across the different prompt types. But for an answer to be correct with a reference, there was a significant difference across these different prompts. And in order to get it correct with the reference, you had to prompt for the reference in the first place. Now, the next question we had is does prompting affect response grade level? We did find that there was a significant association between the prompt type and the Flesch-Kincaid grade level. Prompting for references, we can see all the way on the right-hand side here, led to significantly higher grade level than all other prompts. And prompting for the 8th grade level led to significantly lower grade level than no prompting. But the 8th grade prompting led to a significantly lower grade level. But what was that grade level? It turns out that it was at grade level 13.43, which corresponds to a collegiate level of grading, which is much higher than what is recommended for patients. Again, we recommend the NIH and the AMA recommend it be at or below the 6th to 8th grade level. So the next question is, well, how low can we get the grade level? So what we did next is we sequentially prompted the chatbot to try and present it at a lower and lower level. So we could see the prompts that we initially gave were at the 8th grade level. And then we said, present the information at the 6th grade level. And then we said, present the information at the 4th grade level. We wanted to see how low we can get it. Can we kind of hone in on that 6th to 8th grade level? And we found that there was a significant stepwise decrease in grade level with each prompt. However, 4th grade prompting still generated responses above the recommended reading level, which was at roughly 8.65. The next question, can ChatGPT provide references? So across all the prompts, GPT 3.5 provided 84 total references. Now, 80 of them, or 95%, were from published medical literature. And of those, all of them came from the prompting for references thread, where we specifically said, provide us with published medical literature to support your responses. So the median publication year of these was 2015. It ranged from 1993 to 2021. And important to note here was that at the time of the study, GPT 3.5 was used or was basically run from training data that was up to 2021. Now, the most recent versions of ChatGPT and other large language models have access to the internet, so there's no training data kind of upper limit. But I mean, this kind of it kind of puts in perspective why the upper limit of our, or the range rather, of our published medical literature is 2021, because this is all the training data had up until. Now, the next question is, well, it gives us references. Are these references real? It turns out that 70 of the 80 published medical literature references did have an associated DOI and they were findable online. Okay, so 70 of them were real, but of those 70, how many times did ChatGPT actually accurately report the information? It turns out that 58 of those, or about 83% of those 70 legitimate citations, were accurately reported. That means that the rest of them were 17%, they were incorrectly or completely falsified, the conclusions and findings. And the question is, like, why is it falsifying the conclusions and findings? Well, there's this concept called artificial intelligence or AI hallucination. And this is actually a well-defined concept in computer science and artificial intelligence literature. And basically, it's a confident response by an AI that is incorrect and does not seem to be justified by its training data. And the graphic on the right-hand side is actually from the technical report from GTP4, or OpenAI's most recent version of ChatGPT. And the column essentially is the accuracy. So we could see that the green is GPT-4, which has the highest accuracy. In the science section, it's approaching 80%. But when you go to different versions of ChatGPT, version 2, version 3, and another version 4, we could see that, I mean, the accuracy was increasing with time, but there is a defined rate of inaccuracy. And in that defined rate is where we have this concept of AI hallucination, where you could ask it a question about thyroid nodules, and it could give you a false response that, you know, as a reader, you think that this is being very confident, but it turns out that there is this defined rate of infactuality from the chatbot. And at the time of this study, this was just screenshots from the FAQ section of OpenAI website, where we asked, like, it has a question, can I trust that the AI is telling me the truth? And it admitted that, you know, it's not connected to the internet. And, you know, in this next question, it said, it started to discuss that it'll occasionally make up facts or hallucinate outputs. So if you're a provider and you're thinking about, can I recommend this for my patients? I mean, this has a huge implication, this concept of AI hallucination. So some take-home points from the study. So ChatGPT overall provided appropriate answers to most questions. About 69% of them were at least correct. And importantly, it did not appear to be influenced by the initial chatbot prompting. Now, prompting does influence the ability to decrease the response grade level, and it influenced the ability to provide medical references from medical literature. But despite our 8th grade level prompting, and what you saw even prompting down to the 6th grade and 4th grade level, responses remained at the collegiate level. Significant rates of AI hallucination, specifically regarding the references, may preclude clinicians from recommending ChatGPT at the time of the study. So, like what happens next? What can we do going forward? And this is the part of the talk where I kind of want to take our findings and kind of our conclusions and kind of bring it into the broader realm of artificial intelligence in healthcare and kind of think about how this will affect our patients going forward, not just now, but 5-10 years from now. Now, currently, multiple chatbots exist. You know, the question is, which one is superior? We have OpenAI's most recent version of ChatGPT 4, and multiple other companies, including very prominent companies like Google and Microsoft and Meta. They all have their own version of large language models. Is one of them better for patient education? Is one of them more used by patients? These are all questions that future studies are probably going to delve into. The next question is like large language models are evolving rapidly. You could see at the time of our presentation, GPT 3.5 was essentially the forefront of large language models available to the public, but we're several versions past that now. Even the free version of ChatGPT is probably an order of magnitude more powerful than the version we used for this study. And the question is, will they become more helpful over time? They now have access to real-time internet. And some services, for example, OpenAI's DALL-E, they can create photos, or OpenAI's Sora, they can create videos. And I mean, the video generation aspect of this, I think, has profound implications for patient education going forward. And if I may just present a video of this is OpenAI's Sora, which you can see on the bottom here. It's giving prompts, which are actually quite simple prompts, but it's providing these beautiful video illustrations that are just completely made up by Sora. And you can imagine the implications for patient education. We can give, wound care management instructions. You can give the patients instructions on caring for like post-operative instructions, what to expect from surgery, how to take your medications. And these are videos seemingly being created out of thin air by Sora, which again is just kind of a video generation software created from OpenAI. The next question is, can a targeted sequence of prompts generate ideal responses for patient education? We kind of like delved into this a little bit in our study where we said, prompt for the 8th grade level, prompt for references, but is there an ideal sequence that patients can use to generate an optimal response from the chatbot? And what I find so interesting is these are just 2 examples of graduate level courses from Carnegie Mellon University and Vanderbilt University, for example, that have prompt engineering courses. I mean, this is a topic that will probably be discussed very extensively in the future, and perhaps there could be some sort of integration between computer scientists and providers of healthcare about how to generate the best prompts for our patients. And this is just a little schematic I kind of created to kind of close out the talk and discuss where we are now. So what we discussed today was, patient education, one aspect of AI in healthcare. But I mean, these are just 6 examples of other aspects of of AI in healthcare, included diagnostic radiology, drug and vaccine discovery, administrative efficiency, physician efficiency, and cancer screening and treatment. And just to kind of go into this very briefly, I go into that diagnostic radiology aspect of it. This is an example right here with thyroid nodules. There's this system called Koios, and they essentially use artificial intelligence to grade or kind of give a score of thyroid nodules. So you can see the radiologist is able to kind of put a box around that nodule, and the software itself generates a TIRAD score in 5 seconds or less, which again, the physician can kind of correct it on top of that, which again, in a way, makes this AI even smarter. And this is just one example of how artificial intelligence is kind of coming into the realm of thyroid treatment in radiographic management. And next is these are examples of artificial intelligence designed drugs that are either in or entering clinical trials. This is a screenshot from a table in a Nature publication. And I find this very fascinating. So this is a screenshot of a draft by the U.S. Food and Drug Administration, or FDA, and their Center for Drug Evaluation and Research. This was published just this month in January 2025. And I find this quote very interesting. The FDA admits AI will undoubtedly play a critical role in the drug development lifecycle. And the Center for Drug Evaluation and Research plans to continue developing and adopting a risk-based regulatory framework that promotes innovation and protects patient safety. So we can see even at the governmental regulatory level, we're starting to understand that artificial intelligence is going to play a huge aspect in multiple facets of patient care going forward. This is an example of December 2023 of a patient scheduling system that was created by artificial intelligence. And these are examples of all the different artificial intelligence scribes that are currently being used by physicians. And finally, different aspects of cancer screening, treatment, and treatment access rather, that are all being utilized right now, and all in the last couple of years. I mean, we can see this paper right here is April 2024. This one right here was May of 2023. And I mean, this is just an example of how rapidly exploding this kind of system is. And just kind of going back to our framework, again, we just discussed patient education and AI in healthcare, but there really are so many aspects of AI that I think will be at the forefront of patient management going forward. And just some final thoughts. So, I mean, we're at really a unique moment in history of patient education and our relationship between accessing information more generally. And above all, I think that this kind of talk highlights a new importance of a multidisciplinary approach between medical professionals and computer and software and artificial intelligence and engineers. I don't think there's ever been a time where multidisciplinary interaction between like the software and artificial intelligence engineers is more crucial than now. And again, because remembering the ultimate goal is improving patient health and well-being. Um, and so I hope that this talk can kind of give one example of how artificial intelligence is kind of bringing its way into the management of thyroid nodules and thyroid cancer. And I also hope that it could also zoom out and show you how it will be affecting patients worldwide in all other aspects as well. Um, so that's it. I want to thank everyone for their time. And please encourage you to reach out if you have any questions or want to discuss research projects or just discuss artificial intelligence in healthcare going forward. Thank you.
Daniel, that was fantastic. Thank you very much.
Thank you, Daniel, for such an enlightening presentation of your work. I truly enjoyed reading yours and Dr. Cottrill's paper. I put a couple of slides, more so for the sake of discussion to ask some questions that that we can talk through, and also put some information in there that hopefully will help us and the audience to understand why you are getting the results that you got in the paper. And for that, I think it's important for us to look a little bit under the hood of how those large language models, including ChatGPT, work. And that will make it easier to understand the advantages and deficiencies of using it for patient education. So what we are thinking from the science fiction movies about artificial intelligence is we are imagining androids and maybe terminators, but in reality, the large language models and AI looks more like this. Under the hood, ChatGPT uses a machine learning technology that's called deep learning. You mentioned it in your presentation, Dr. Campbell, which is essentially a very large network of these units, which are called neurons. And those neurons, they are very different from our neurons that we have within our skull. It's just a simple set of mathematical operations, very simple, usually additions and multiplications. And there is a lot of numbers which are flowing through all these neurons, which are densely interconnected. And the idea is that we feed some information into the network, like a prompt in your study, and that text gets converted into the numbers, and those numbers travel through the network downstream, and then we get an output. And the hard part is to create a model such that the path that the numbers take when they travel through the network result in a sensible answer. And to make a system like this, that requires a process of training. And that's how ChatGPT was created. So the ChatGPT was presented with a vast amount of data, mostly from the internet, but also from the other sources. And that's how the model learned a lot of information that it uses when it generates the answers, but also concepts like what is the structure of a human language? What does it mean to generate text? And through the process of training, the model was presented with different questions similar to yours related to thyroid nodules. And the outputs were evaluated and initially evaluated by a computer, and feedback was given to the model. So imagine in the very first iteration, the text output was garbage, probably was not very useful. But each time, the large language model was given some information of how to improve and how to tweak those paths that information takes when it travels through the network. But computers can do only so well when evaluating the quality of the text outputs. That's why OpenAI hired an army of human employees, which provided a human feedback, which rated responses of the model in a way that they think are most appropriate. And that's how those large language models they acquired that ability to give less harmful and maybe what looks like an empathic answers, polite answers. So I tried to think of some strengths and also some deficiencies of artificial intelligence. And one obvious strength is that ChatGPT knows about many things. That is because it was trained on the world of information, of the text information, mostly from the internet. And that explains why, for example, if you use AI to test it, give it standardized medical questions, such as USMLE examination, it will perform well. I think of it as some sort of cheating because in contrast to the physicians taking this exam, ChatGPT knows all that information in the internet. And also it provides responses which sound polite and empathic. And we just went through some ideas of why the model works in such a way. But there are some challenges, which, Daniel, you mentioned. One is hallucinations. If you think deeply of how the model works, it also becomes clear why hallucinations exist. For example, if I asked ChatGPT a simple question, such as what is thyroid nodule, then I would expect there is a lot of information in the training data about this, and there is a path through the model which would give a correct answer. But what happens if I ask a question which is difficult? Maybe there is not much information out there, or even a question which is impossible, where the answer doesn't exist. The model is designed in such a way that it still has to give an answer. And that is why, instead of giving a correct information, which may not exist, it would provide the next closest, which is something that looks like a correct information, but it doesn't. And my first question to you and Dr. Cottrill and to the panel is, you show that graph that the newest model can get it wrong up to 20% of times. And I imagine that would not be an issue for a high school student writing an essay on medieval history. But in healthcare, we live in a high-stakes world. And do you think that accepting that high percentage of potentially erroneous answers is acceptable for patient education? And I'll move forward with my presentation, not to affect the flow of this. And so those questions are mostly to fuel the discussion at the end. And another problem is there is an information cutoff, particularly for GPT 3.5 that you used in your paper. It's actually January 2022, which means that the model is oblivious to any information that happened after the date. Again, in the healthcare is a very dynamic field, and it literally changes from months to months of how we treat our patients because it's such a dynamic field. Thinking more specific about the use case in your paper, the American Thyroid Association is currently working on a new set of guidelines on how we will diagnose thyroid cancer and how we will manage thyroid nodules. So at some point when those guidelines get released, the large language models will provide incorrect answers, at least for some time, before they are retrained or they learn to retrieve that information from the internet. Do you think that is a problem? Okay. And my next point is technology is rapidly evolving. And every month or every few months, we have a new model released. Chinese DeepSeek model is right now big news and created quite a turmoil in the science world and in the stock market. So I got curious and I took one of the questions that performed the worst in your study, which is this question number 10. And I used GPT-4 model. So that's a next generation model compared to the one you used, and asked that question. I slightly changed it to be more explicit that I'm asking about thyroid nodules. And I got this answer, which using your scale, I would give it dark green on a heat map, correct plus reference, because that cites from the American Thyroid Association, and the information here is correct. Like you said, it is not easy to read. It is clearly not an 8th grade. This text was written in the guidelines for healthcare professionals. But the point I want to make here is those models are evolving rapidly, and as expected, they start performing better and better. The research that you did, do you think it's still relevant? And is it worth of doing that comparison between the models that you proposed in your slides? Because very soon it will become obsolete again once the big technology companies will invent a new technology. So my next question, do we actually need to go to ChatGPT to answer the questions? So these are first 15 answers from your paper. And I went to the website from the American Thyroid Association and opened a brochure on thyroid nodules, read through it and said, well, how many of those answers how many of those questions have answers in that brochure? And as you can see, I was able to answer most of my questions, but not all of them. So here is, we clearly see an advantage of AI tool because it knows a lot more than any expert would put in the brochure. But also going to a reputable source like the American Thyroid Association website would avoid any potential pitfalls like hallucinations or outdated data. This is the gold standard written by experts who know everything about the topic. I wanted to mention this paper. I'm not sure you have, I'm sure you have seen it. It used very similar approach to your study. Slightly different. There were 8 physicians who assessed responses from ChatGPT, experts in the field, 4 endocrinologists and 4 endocrine surgeons. They also asked questions about thyroid nodules and thyroid cancers. And those experts had a relatively modest assessment of the performance of the GPT, when only slightly about half of the responses were considered to be agreeable or strongly agreeable on a Likert scale. And the conclusion from this paper is that ChatGPT is not accurate and it's not reliable enough and shouldn't be used to educate patients with thyroid cancer. So how do you compare this conclusion to a slightly different and more excited result from your paper? So to leave some time for the discussion, this is my slide and my take on whether we should use artificial intelligence for medical information and patient education. And my take is as follows. I will send my patients first to the websites that I trust, like the American Thyroid Association information for patients. And I suspect that for many, the information in those brochures will be sufficient. Those who are interested in more data, which cannot be found on those websites, using artificial intelligence, including ChatGPT, understanding its limitations, is acceptable in my opinion. The most inquisitive individuals would benefit from verifying the answers from the artificial intelligence by looking at the primary literature, which is not obviously for everybody. It requires quite a bit of work. But none of this, I think, replaces a more standard approach, which is number 4. Talk and trust your doctor. If you have an endocrinologist, expert in the field, they should be able to give you an unbiased and up-to-date response without all the pitfalls of going on the internet and looking for information in there. And I think, as you mentioned in your slides, we will watch how the technology develops. I'm sure things will change as we live in a very exciting world. And I thank you for your attention and the opportunity to think about this important problem and get myself more familiar with Dr. Campbell's and Dr. Cottrill's research.
Thank you, Nikita. And I think you have posed several questions. Elizabeth, do you mind if you perhaps start answering some of those?
Yeah. So I had a couple of, I mean, obviously there were multiple questions that were posed during this. I would say the first thing that kind of comes to mind is sort of the idea that we get to say that it's not safe or it is safe is true. We can certainly say that, but it doesn't change the fact that it exists and our patients absolutely will go to it. So it's really our job to sort of understand what's out there, what is trustable, how can we guide our patients a little bit? Okay, you're going to use it, so here are some maybe guardrails or some suggestions about it. I very much agree that, you know, having the handout right there in the clinic to give my patients from the ATA is ideal. It has the website at the bottom. I tell them to go to that website and look for more information, but they still have, you know, their niece, their nephew, their aunt, their brother that looked things up on the internet and has more, you know, questions and more information. I think as you pointed out with these new models coming out and the ever evolving, ever renewing sort of truth question, you know, quote marks in medicine, it really is truly a nearly impossible task to ask that patients, not providers obviously, but patients are kind of being presented with from the internet, from a model, from a ChatGPT or whatever, always the most relevant or most recent, because it does take into consideration all of these things. So what, you know, will our models, or, you know, will our search engines know that the 2025 guidelines need to be the gold standard and don't look at any of the data, don't look at any of the guidelines from before. How do we know that they're doing that? We don't, because it's a black box, right? So the learning, as you mentioned, it will take time. It will take time to get better, and I think it will eventually hopefully get better. But there's, as we all know, a lot of truth and untruth on the internet, and there are lots of sources that it may be pulling from. I think when you, as Dan was mentioning, when you know how to prompt, it may guide you to a more correct answer. And I think that that's really the way that we, you know, identified this study to kind of be helpful. Is, hey, if you're understanding the way you might ask the question, you might get to a more reasonably correct answer. And not all the time, as we showed, it wasn't always correct. But it does help to know what types of things to ask asking for a reference is going to potentially get you to a more correct answer. So those are my initial reflections. Yeah.
Thank you, Elizabeth. Daniel, do you want to add or to comment on
Yeah,
those?
I think that, so I have a lot of the same sentiments as Dr. Cottrill, and another kind of aspect of that I wanted to emphasize is the question of like these things are rapidly evolving, and it brings the question that I think it was also brought up in the previous slide deck is like, is this research necessary? If like by the time it published, there may be 2, 3, 4 versions that have already kind of gone through the realms of patient education, and then by the time you're able to publish on that, there'll be 2, 3, 4 realms after that. And I think the short answer is maybe. One, it allows for discussions like this. It allows for healthcare professionals that may not be too savvy in the internet, but they may be reading medical journals to kind of understand what's going on. And I think finally, the most important aspect of it is that I think we just need to really focus on like collaboration between the different facets of who's making the large language models, like people like computer scientists, data scientists, people that are kind of in the artificial intelligence space. I think that kind of integrating them into healthcare, into people that are in the forefront of patient education, will probably be like the best way going forward in terms of making sure that what patients are seeing on these sort of things and how they're using it gets like optimized really for patient education.
And there is a question from the audience, and I'm gonna ask you, Nikita, about this one. Is always the question of which of these tools and their tasks need FDA approval. So something like this, would we consider something that needs FDA approval before we ended up using in practice?
Yeah, that's a great question because of the potential harm that these tools could result. The use of these tools could result into. My take for critical questions like Daniel presented that COIUS tool, which effectively tells the provider whether the nodule is likely to be cancerous or benign and whether it needs to be biopsied or not. FDA approval is essential because the implications from incorrect assessment are serious. I also realize that it's impossible to regulate large language models like ChatGPT.
Mhm.
And objectively, it's hard even to objectively assess of how it performs in all the domains of medicine. So that's a gray zone. Also thinking of your example from your talk, Daniel, when you were proposing a video which would guide a patient of how to do a wound care management. In my head, this is one of those more risky applications because what if the model hallucinates an incorrect guide on how to manage the wound that potentially could result in a serious damage to the patient. We should look into this technology very carefully and also be cautious when we advise our patients to use it.
Thank you, and we are approaching the end of our session, and really would like to thank all of you. Fantastic presentation, I think very insightful comments. I encourage everyone to visit our website, thyroid.expert, for more resources and updates in thyroidology. Next week, we have another exciting webinar. Is Dr. Robert Scott is going to be presenting approach to the patient with thyroid cancer, selection management, and candidates for lobectomy. So please sure that you tune that to that session. And again, thank you very much for everyone who has attended, and thank you very much for all the speakers as well.